The next topic is the glaucoma. So in this lecture, we are going to discuss the primary congenital glaucoma. We will leave the secondary glaucomas or the secondary congenital glaucomas to the glaucoma lecture. So what is the primary congenital glaucoma? The etiology of a primary congenital glaucoma is an angle dysgenesis, like the angle didn't form normally. So there is, if you consider this like the normal trabecular meshwork, and this will allow the aqueous to pass smoothly from the anterior chamber of the eye to the venous sinus system of the episcleral veins and others. So it will be like a normal smooth passage. However, in those patients with primary congenital glaucoma, the trabecular meshwork openings are not well aligned, leading to that the aqueous will not be able to pass outside the eye, or will not be able to drain through the trabecular meshwork to go to the canal of Schlemm and the venous system of the eye. So this will result in that the aqueous will be trapped, increasing the intraocular pressure. So it is an angle dysgenesis. So a cause of primary congenital glaucoma will be genetical abnormalities in the trabecular meshwork and the anterior chamber angle, resulting in elevated intraocular pressure. And since it is primary, so there is no other ocular or systemic developmental anomalies. For the secondaries, we will talk about other. It can be congenital glaucoma can be an association with wide range of ocular and systemic diseases. But we will leave that to the glaucoma lecture, okay? The incidence of the primary congenital glaucoma will follow the 2/3 rule. This is also commonly asked in the MCQ exams. What is the 2/3 rule? 2/3 of primary congenital glaucoma are primary, or 2/3 of congenital glaucoma cases are primary, while 1/3 is secondary. 2/3 are male, 2/3 are bilateral cases, and 2/3 are diagnosed by 6 months. So it is not always that the congenital glaucoma is diagnosed at birth. And this will bring us to the onset. What will be the onset of primary congenital glaucoma? Depending on the age of onset, the glaucoma can be classified into, or the primary congenital glaucoma can be classified into 4 categories. The newborn onset, in which the primary congenital glaucoma will be diagnosed between from birth till 1 month, which is the neonatal period, or infantile onset, which will be diagnosed between 1 month to 24 months, or in the first 2 years of life. Late onset or late recognized, which will be diagnosed after 24 months, or a very rare occasion where there is a spontaneous regression of cases or spontaneously arrested cases. Like you find a case of congenital glaucoma with Habs tria, but with normal intraocular pressure. So what happens? It happens that those patients had congenital glaucoma, they had Habs tria, but suddenly they are, for unknown reason, the progression of glaucoma was arrested even without treatment. This is very rare. However, it can occur, and we always need to follow up those patients as glaucoma suspects. They can develop high intraocular pressure at any time. So what will be the clinical presentation for those patients? Those patients will have some symptoms like tearing, photophobia, and blepharospasm, and eye rubbing. You remember the last lecture when we said that when you find a patient or a child or a neonate or infant at the present with tearing, you suspect that it could be a congenital nasolacrimal duct obstruction. So it will be the most common, but the most serious to exclude is the primary congenital glaucoma. Because those children or those infants will present with tearing, photophobia, blepharospasm, and eye rubbing. If younger than age of 3 months, sometimes the child or the parents will not notice the presence of large eye or the presence of photophobia or blepharospasm. So usually they present with corneal clouding, or tearing, there will be break in the isthmus membrane causing scarring and edema. If the patient is older than 3 years of age, they are usually asymptomatic with progressive myopia and insidious visual field loss. So those children may not be complaining of any symptoms. They will just showing a progressive increase of the size of the globe. So they sometimes be mistaken or misdiagnosed as myopia, but they will show insidious visual field loss. They will show slowly progressive visual field loss. So these are the symptoms. What will be the signs? You will find high intraocular pressure of more than 21 millimeter mercury. The cup to disc ratio will be more than 0.3. In ophthalmos, this is the other name, the ophthalmos, the horizontal corneal diameter is more than 13 millimeters. So this can be a differential for megalocornea, as we just mentioned. Also, they can present with corneal clouding, corneal edema, HAB stria. As you can see, this horizontal stria are very suggestive for congenital glaucoma. So if you see this a child, what will be your differential diagnosis? The first is the differential diagnosis of epiphora. So if a child present with epiphora or tearing, you suspect a nasolacrimal duct obstruction. So you do a regurg test that we mentioned last time. Conjunctivitis or corneal abrasion, keratitis, and uveitis. It's worth mentioning that the photophobia and the blepharospasm are unlikely to happen with the nasolacrimal duct obstruction and the conjunctivitis. So this will be a good sign to differentiate that nasolacrimal duct obstruction and the conjunctivitis will not have, or the patient will not experience a photophobia and blepharospasm. Keratitis and uveitis. Dr. Muhammad, can I ask a certain range for normal IOP in children or not? A number above, I suspect the glaucoma, it will be 21. High intraocular pressure more than 21 millimeter mercury will be, you should suspect a congenital glaucoma or glaucoma anyways. For corneal clouding or opacification, this is another differential diagnosis. We remember the mnemonic stamped. We can also, this will be with all features that we discussed. This can be also differential for congenital glaucoma, because congenital glaucoma can cause corneal scar and opacification. Corneal enlargement will be the high axial myopia and the megalocornea. We also discussed that those patients will have normal intraocular pressure. They will have clear cornea. There is no HAB stria. And also from other differential diagnosis of optic nerve cupping, like physiological cupping or optic nerve coloboma, optic nerve atrophy, optic nerve hypoplasia, and optic nerve malformation. This can cause optic nerve cupping, but they will be unlikely to cause large globe or myopia or megalocornea or HAB stria. So here the pathology is limited to the posterior segment. So this will be the differential. How can we diagnose a patient with primary congenital glaucoma? If the infant is young and uncooperative, so we will need to do examination under general anesthesia. So this will be for most of cases. Diagnosis can be done by measurement of the intraocular pressure using different tools like applanation tonometer. If we are doing examination under general anesthesia, this can be done by Scheutz tonometer or the Perkins tonometer or the by tonopen. Measurement of the horizontal corneal diameter, and this is all by a caliber. Gonioscopy, if there is no corneal edema, so you can do gonioscopy to check for the angle status, to diagnose also the secondary causes like Axenfeld-Rieger anomaly and others. The axial length should be measured by a scan so that you can confirm the presence of axial myopia. Pachymetry to measure the central corneal thickness. So for patients with glaucoma or congenital glaucoma with the corneal edema, then the corneal thickness will be thicker. However, if there is no edema, the cornea tend to be thinner. This is due to stretch. So if there is edema, there will be thicker cornea. If there is no edema, the cornea will be more thin. And perimetry, or the visual field analysis, can be done by the age of 7, 8 years old if the child is cooperative, as this will need a cooperative child. And OCT can be done if we can make the child sit on the slit lamp. In this case, we can do an OCT scan in order to measure the retinal nerve fiber layer. So these are the different modalities used for diagnosis and follow-up of patients with primary congenital glaucoma. Regarding the management, the definitive management is surgical. We just do medications as a temporary measure. Like if we diagnose a patient with primary congenital glaucoma for the first instance, we just control the intraocular pressure by medication as a temporary measure, but this is or awaiting the surgery. There are certain precautions regarding the medications that those children should receive. The most important is the alpha agonist. The alpha agonist is contraindicated in children less than 2 years old. Why? Because it can cross at that time, those children don't have a well-developed blood-brain barrier, so it can cross the brain, leading to affection of the respiratory center and the cardiac center present in the brainstem, causing like high apnea and even death. So this is fatal. This should be avoided in patients with who are very young. Also, it should be used with care, the beta blockers. The beta blockers should be used carefully because there will be like increased response to the beta blockers in the children. There will be a higher incidence of increased systemic absorption. There is higher incidence of binding to the plasma proteins. Like there will be more response to the same dose of beta blockers in the children than in adults. So this will be the medical management. Regarding the surgical management, we take like a stepwise manner for management of primary congenital glaucoma. So if one step is failing, we can proceed to the next step. First step is the goniotomy. What is the goniotomy? As the name implies, we are doing incision in the angle, or the anterior chamber angle. This can be done from the limbus, like we are passing a knife through the limbus. It's called Barkan knife. And we do incision in the trabecular meshwork, trying to open an incision for drainage of the aqueous. So as you might expect that in order to do this, you have to have a clear cornea. And we said that not all these children have clear cornea. Some of them will have corneal edema. So if in this case, we don't have the luxury to do goniotomy. So what will we do? We do what's called trabeculotomy. Trabeculotomy is when we are opening a scleral flap like that and pass another like a tool or a cannula. It is called the trabeculotome. This trabeculotome is passing or cannulating the canal of Schlemm under the scleral flap and opening it toward the anterior chamber. So you see this arrow, you are passing it into the canal of Schlemm, then you sweep internally in order to open the trabecular meshwork and the canal of Schlemm to allow communication between the anterior chamber and canal of Schlemm. So this will do the job if the cornea is not clear. So we do trabeculotomy if the cornea is not clear. If these procedures fail, we do trabeculectomy. And trabeculectomy, we are creating a blip, or we do what's called subscleral flap, allowing a drainage of the aqueous from the anterior chamber to the subscleral space, creating a blip in order to bypass the trabecular meshwork. So see, this is the blip. And we use the mitomycin C in order to increase the chances of success of the surgery by mitomycin C as an antimetabolite. If all this failed, we do what's called a drainage implant, like Bervelt valve or Ahmad's valve, or Ahmad's valve or Bervelt tube. So Bervelt doesn't have a valvular action. So those devices can be implanted on the scleral side and allowing a tube that will enter into the anterior chamber, causing direct drainage through this tube, which will be the most successful procedure in congenital glaucoma. And finally, if there is all this doesn't work, we can do what's called cycloablation of the ciliary body, like by destruction of the ciliary body, not all the ciliary body, by most of the ciliary body, by laser, by diode laser, in order to decrease aqueous production. This was in the past used for end-stage glaucoma where there is no visual potential, but nowadays it can even be used for patients with visual potential. Okay, so these are the different lines of management of patients with primary congenital glaucoma. Is it clear? Any question? Okay, so let's move to the next topic. So we talked about the cornea and the glaucoma. What will be the next? Let's see what will be some iris anomalies or iris abnormalities that may happen to those patients or the pediatric population. First of all, the aniridia. What is meant by aniridia? Aniridia, if you try to analyze the name, it means that there is absence of the iris. There is no iris. But is this always the case? Actually, no. Usually, aniridia refers to the presence of a very small rudimentary iris stump. So this iris is not absent, is not totally absent. It is just there is rudimentary iris, very small minimal iris is present. And actually, this is like maybe not very good thing because this iris sometimes roll on itself, causing secondary angle closure glaucoma, as we are going to say in the glaucoma lecture. So this is actually one of the causes of secondary congenital angle glaucoma, specifically an angle closure glaucoma, because of the rolling of this rudimentary iris, causing that the iris will push, with this rudimentary iris will be pushed against the angle, causing angle closure. That's why this rudimentary iris can, this case of aniridia, in 50% of cases, those patients may have glaucoma. Okay, so bilateral absence of the iris, commonly a rudimentary iris stump is present. The etiology of this case, it can be hereditary or sporadic. And for hereditary, it was mapped to chromosome 11 in the short arm of the Lucas 13, which is belong to the PAX6 genes. PAX6 genes, okay? Now let's see what is the most important part of aniridia is the types. The aniridia is classified into 3 types: aniridia type 1 and type 2 and type 3. The most common is aniridia type 1, which is around 85% of cases. It is autosomal dominant and only eye involvement. Like this means that in type 1, it is only isolated aniridia. There is no systemic involvement. Okay, so this is for the autosomal dominant. So if you follow the pattern of inheritance, or if the question say that the parent is having aniridia and the child also have aniridia and the mother is normal, and if you say that it is autosomal dominant, so if they ask you if you expect that you find other systemic abnormalities, the answer will be no. It is only eye involvement. Aniridia type 2 is the most important. Although it is only 13%, it is sporadic, so you will not find the parents affected or any familial affection, but those patients will be associated with what's called Weger. Weger syndrome is the presence of Wilms tumor or a tumor of the kidney called Wilms tumor, aniridia, G for genitourinary abnormalities, and R for mental retardation. So those patients with aniridia, you need to ask about the family history to if they are sporadic, So please do the patient a favor and send him to do ultrasound on the abdomen for the presence of Wilms tumor. Aniridia type 3, it is autosomal recessive and associated with mental retardation and ataxia, sometimes referred to as Gillespie syndrome. Okay, so again, 3 types of aniridia. Type 1, autosomal dominant, only eye involvement. Type 2, associated with Weger, it is sporadic. Type 3, it is autosomal recessive and associated with Gillespie syndrome. So what will be the clinical presentations? It is a rudimentary iris. Those patients usually have poor visual acuity, like 660 or worse. Why? Because they have associated foveal and optic nerve hypoplasia. And since the presence of foveal or optic nerve hypoplasia, this will be associated with nystagmus. Since that they don't have any iris covering the eye, or there is no iris in the anterior segment, this will lead to increasing the exposure of this eye to light, leading to photophobia. The optic nerve and the foveal hypoplasia will lead to amblyopia and strabismus. They can be associated with cataract for 50% of cases. Also glaucoma. A type of glaucoma is the angle closure glaucoma or secondary angle closure glaucoma in 50% of cases. The ectopial lentis and the corneal pannus. Okay, what about the management? How can we manage a patient with aniridia? For those patients who have low vision or low visual potential, so a visual aid, low vision aid for those will be beneficial, especially for those who have significant visual impairment. They can have a cosmetic or contact lens for or painted contact lens for the photophobia to decrease the amount of light. Iris implant can be considered, however, the risk of glaucoma is also shouldn't be overlooked or shouldn't be neglected. Those patients have already more incidence of secondary angle closure glaucoma. And also, if those patients develop the cataract, this should be managed by cataract surgery. If they develop the glaucoma, this can be controlled medically or surgically. The follow-up, don't forget, for those patients who have Weger syndrome, they require renal ultrasound every 3 months and the follow-up by pediatric oncologist until the age of 8 years old, until we confirm that they didn't develop the Wilms tumor. Okay, so I hope that this is clear. The next thing about the iris, and not only the iris and the other ocular structures, a congenital anomaly that happens in iris and different ocular structures, it's called the coloboma. So a coloboma is a missing piece of tissues in the structures that form the eye. So we have different ocular structures. These ocular structures are during embryonic life, there could be some missing part or missing pieces. Why does this happen? This is because of what's called the closure of embryonic fissure. Like the coloboma is uncommon unilateral or bilateral congenital condition caused by incomplete closure of the embryonic fissure. I just forgot to bring you a picture of the embryonic pressure or embryonic fissure, but I can draw it for you. So let's say that this is called the embryonic fissure. Which will include the optic nerve, the central retinal artery, central retinal veins, which are the hyaloid vessels during the intraorbital life. This embryonic fissure should be closed in the 3rd trimester. And this will result in closure of different ocular structures. If it is remaining patent or opened like that, this will result in incomplete closure of the embryonic fissure, leading to different congenital anomalies in the eyes termed as colobomas. These colobomas can be sporadic or autosomal dominant if they are bilateral. And the commonest location, as you can see here, it is below, it is inferior, as the location of the embryonic fissure is infranasal or in the lower location. So most common location of the colobomas are infranasal. So what are the types of coloboma? It could be an eyelid coloboma. You can see there is a defect in the eyelid. Or it could be iris coloboma. Here you can see there is a defect in the iris. Lens coloboma. This is lower nasal defect of the lens. So there is absence of the lens and the absence of the zonule. Chorioretinal coloboma. Here, this is a chorioretinal coloboma. And also optic disc coloboma. So all these are defects in the ocular structures due to incomplete closure of the embryonic fissure. Clinical presentation depends on which type of colobomas, but like if we are talking about chorioretinal colobomas or optic disc colobomas, mostly the which are concerned more with vision, so they will present with visual field defects and a relative afferent pupillary defect. And there have an important associations of the colobomas that you need to know for ocular findings or systemic findings. For ocular findings, like if there is one coloboma, it can be associated with other tissues coloboma. There could be, if there is iris coloboma, there could be coloboma of the lens, ciliary body, choroid, optic disc, retina. Can be associated with microphthalmos, with orbital cyst, persistent hyaloid artery, and retinal dysplasia. Also can be associated with systemic anomalies. The most important, which is asked in the exams, is the Charge syndrome. I'm going to discuss it right now. Trisomy 13, Meckel syndrome, which is a bilateral ocular disorder associated with multi-system developmental anomalies. Aicardi syndrome, in which there is bilateral ocular condition characterized by cranial anomalies, choroidal pigment, epithelial, and skeletal anomalies characterized by what's called the presence of choroidal lacunae or lacunae. It's called the Aicardi syndrome and Meckel syndrome. The most important is the Charge syndrome. In the Charge syndrome, you can see that the child has a coloboma. There is iris coloboma. So Charge, actually, again, every letter will count for an association. So C is for coloboma, H for heart disease or heart problems, A for atresia or choanal atresia. Those patients have in the nose, they will have choanal atresia. R for retarded growth, G for genital anomalies, and E for ear anomalies. Okay, so if they ask you in the exam, what will be the associations of Charge syndrome, you know now what are the elements of Charge syndrome. Okay, clear? Okay, so let's now talk about the lens disorders. So in order to discuss the lens disorders, again, we will not cover the congenital cataract or congenital lens opacities. We will discuss this in the lens lecture. So I'm just trying to optimize the lecture depending on the exam needs. So in the exam, specifically the ICO exam, they tended to ask about specific things in the pediatric ophthalmology section. So this is what I'm discussing here, and the remaining will be discussed in the relevant lectures. Okay, so for the lens, what's asked in the pediatric ophthalmology section is the congenital anomalies regarding the lens shape, which is the microspheropheckia and the lenticonus. Let's start first by the microspheropheckia. What is meant by microspheropheckia? Micro, it is a small. Sphere, it is spherical. Pheckia is the lens. So it is a small spherical lens. So what is the normal? The normal is the lens is lenticular in shape. So the lens is lenticular in shape. But in this microspheropheckia, the lens is small and spherical. This condition is usually bilateral, with the zonule are visible on dilatation, since that it is a small, so you will find that the zonule attachment, they are present on pupillary dilatation. Those patients will have iridodenesis, like there will be tremulous iris. The problem, or the most commonly asked question here, is the pupillary block. You can see that this lens, since it is small, it can jump very freely into the anterior chamber. So for those patients, if you do give them myotics, if you try to give them myotics, making the pupil small, then this lens will be adherent to the small pupil, causing pupillary block, leading to angle closure glaucoma. So myotics here are contraindicated. Otherwise, we are always giving mydriatics, like or cycloplegics, like this. We are dilating the pupil. Important associations that happen with microspherophakia is Weil-Marchesiani syndrome, hyperlysinemia, Lowy syndrome, Alport syndrome, congenital rubella, and Peters anomaly. For treatment for those patients is cycloplegic, these cycloplegics will cause tightening of the zonule and flattening the lens and pulling it posteriorly. So it will be like a question appeared before that you can do like gentle tapping over the cornea if the patient is cooperative and in the prone position, or in the supine position. So you can do gentle tapping, trying to reposition the lens posteriorly. And of course, this can be this lens can be managed by lensectomy, removing the lens and with a secondary IOL implantation. So this will be the microspherophakia. Regarding the lenticonus, the lenticonus is the keratoconus. So the lenticonus is that the lens assume a conical shape. Like the keratoconus, the cornea assume a conical shape. In the lenticonus, it is a cone-shaped lens deformity due to central bulge in area of the thin capsule. So this can be anterior or anterior lenticonus. So there will be a bulge in the anterior lens capsule filled by the lens, causing anterior lenticonus, or it can be posterior lenticonus. There is a bulge in the posterior capsule leading to a posterior cone. Both are very important in the exams. What will be the difference between the anterior and posterior? The anterior is bilateral. The posterior is unilateral. The anterior occurs in males more than females, while in the posterior in females are more than in males. Anterior has very important associations that is asked in the exams, which is Alport syndrome. Alport syndrome is a triad of anterior lenticonus, hereditary nephritis, and deafness. Again, Alport syndrome is a triad of anterior lenticonus, hereditary nephritis, and deafness. Remember, A for A, anterior for Alport. The posterior is more common than the anterior type, with the amblyopia is more common. So these are few lines here, or these few sentences carry lots of questions in the exam. So remember, the lenticonus, anterior and posterior, anterior more commonly to be bilateral, posterior to be unilateral. Anterior in males more than females, in the posterior in females more than males. In the anterior is associated with Alport syndrome, in the posterior it is sporadic. Alport syndrome is anterior lenticonus with hereditary nephritis and deafness. In the posterior it is more common, and with amblyopia also more common. Okay. So this is for now for the pediatric lens diseases. We will continue the remaining lens diseases in the lens lecture, lens and the cataract. Okay, so let's now move to the next topic.